in the new terminology, notably artificial intelligence, AI, machine learning. Some of you know about NLP, some of you don't. Now the ChatGPT large language models, it's very confusing. Like I said, nobody, certainly not me, has a monopoly on truth. But I like to say I'm definitely not in the 100th percentile, 99th percentile, but I'm in the 90th percentile on a lot of these things. And I'm having a hard time trying to integrate and combine them. So I want to share some of my observations, and then we'll end up with what does this mean for the future. I like this slide. Again, everybody, I'm happy to share all the slides if you just came in or just joined us. And everything has a URL, but there is no consensus. I can't really go point it or it messes up the camera. But the concept, no two pundits or experts in this field will draw the same Venn diagram. And anyone that says this is AI or this is data science or this is machine learning, or now this is 2 years old, and their question answering is the little small thing that's now the ChatGPT and the LLM. So just to show you how quickly things are rapid. There is not consensus. And the statisticians, I don't know if we have card-carrying statisticians in the room, we have a few, will scratch their head and they'll say, what are we, chopped liver? They've been working in this domain, doing very advanced work. And so just a heads up that there is not full consensus. That said, I also wanted to pause about large language models. I myself, in the 90th percentile, but not 100th, was confused. And I found this chart helpful. Machine learning, which we'll get to in a moment, and natural language processing. Most of you are familiar with those terms. And deep learning, which many people consider that a type of AI. It's really large language models, at least among some camps, are considered a subset, like I've drawn it there, or like someone else drew it there. So, a type of deep learning that is indeed natural language processing, that is indeed machine learning. All right, so this is a textbook definition, not necessarily one everyone would accept, but it's the one that the US government in health uses. At least they did a year ago. I made fun of them when there was a office of the chief AI officer of HHS. I don't make fun of them anymore. They were a couple of years ahead of the time. Artificial intelligence enables computer systems to perform tasks normally requiring human intelligence. Not bad. Machine learning, a type of AI, and some would say it's not all AI, but anyways, this is their definition. I didn't invent it. That gives computers the ability to learn without being programmed by humans. We'll accept this for now. Some of you might have others. Now, this is my read on it as someone that's trying to make sense, both for health policy and management and the School of Public Health and Johns Hopkins system. Of course, in most places, AI is owned, all due respect to any colleagues from these places, by tech companies or in computer science. I like a lot of tech companies, and I like a lot, if not most, computer scientists. But when you come in to it and talk about healthcare or public health or health services research, it really needs to be a broader discussion. It also goes, if any of our colleagues at the Whiting School are listening, it takes all sides, and I think many acknowledge of computer scientists, public health scientists, clinicians, and those that are conversant in multiple domains. And that's actually one of my words for any of you that are either on the health services or public health side or clinical side, or I know we have bids and computer scientist people here too, being able to work together. All right. There really are 4 different domains. When I turn on the TV or open a newspaper or watch a special or see something online, there are 4 different domains that are definitely interrelated. The whole chatbot applications, which wasn't hot a couple of years ago, but is now, and the large language models, I view that as a way to manage information overload and knowledge repositories. Is that a completely good definition? No, but it's good enough for now. If you want to write a paper, or if a clinician wants to check the latest on a certain type of condition, that's what, is that AI? Yeah, that's certainly what many people consider that AI. The whole generative, obviously the crazy pictures and music and other things, it basically generates new things, but not really new things. They're stealing old things, integrating old things. What people know about this? People don't pay a lot of attention to automation. When you go online and you see all these companies offering AI, what they're really offering is what previously was called automation or digitalization of processes. Clinicians among us here, when the system is coming in with digital workflow and saying, don't worry, we'll back you up with the computer and it'll help you make decisions if you miss it, clinical decision support, and a lot of other things. I call that really the automation and digitalization of administrative clinical work processes. Is that AI? I think it's more AI than you think. It's really, so all the banks say they use AI, all the phone companies and everybody else is saying they use AI, but this is really what they're talking about. Now, robotics and sensing. That's hugely important. I don't claim to be an expert on it. The one thing I want to highlight is there are many devices and scientists spending time on interacting with physical world, sound, and visual. 80% of all the Food and Drug Administration's FDA's approval of AI relates to this category, imaging. For any radiologists in the room, but that is the CT and MRI and eye scans and other things. That's a brave new world, and that is today. Now, the rest of this talk, for the remaining 25 minutes or so, will focus on the area I know the best. And depending on the audience, if it's a healthcare audience, when people talk about predictive modeling, when people say, let's use AI for the medical record, so docs and others can know what to do from the data, or, oh, I don't need RCTs, randomized controlled trials anymore, or I don't need epidemiology or health services research anymore. After all, I can use these huge EMR databases and apply AI and they'll give me the answer, which is, big discussion and a lot of people have. This is the area they're talking. Extracting and creating knowledge from raw big data. It used to be called a couple of years ago, big data, analytics, predictive modeling. Now I would say 95% of the time it's AI. Some of you might have heard the CPHIT posted the new NEJM AI journal editor last Friday, I guess it was. I was a discussant. She's a very nice Norwegian lady who has come over to head the New England Journal of AI last week. JAMA announced. JAMA AI, Nature, and Lancet and BMJ are already there. And I think it's great on one hand. On the other hand, the idea of calling it all AI, I sort of scratch my head. That's going to be the next 10 minutes of the talk, is talking about that. I think I've already mentioned this. The big data domain is the one that I'm going to focus on. It's central to all of our fields. It's certainly central to the Center for Population Health IT, and it's what I know best and I will talk about. I'm not saying that robotics is not important. I'm not saying that ChatGPT is not important. And I'm not saying that automating processes are not important. But to the extent people are saying, gee, we don't need biostatistics, we don't need epidemiology, we don't need econometrics, what we need is AI, that's what I'm going to be talking about the next 10 minutes, all right? And people say, what do you think about it? I've been using, some of you know me, know that I like metaphor and analogies. Someone suggested, oh, it's really just the icing on the cake AI. Maybe that's the way of doing it. Others have said, well, it's really the tip of the iceberg, meaning the machine learning, the LLM, the boost techniques, neural nets, that's that. But what about data that are garbage? Let's develop data that aren't garbage. What about understanding numerators, denominators? What about looking only under the street light because that's the data you have, when what really matters is the person's social factors? I don't have to teach you. You can all teach me a lot of the other areas of expertise that you have. So my argument is all of the stuff that we bring into a research study should not be left behind when we add machine learning or LLM into it. How we do it together is challenging. Let me give you some example. That's what I was just saying. So the econometrics, biostatistics, and I'll show you in a moment, when you side by side do good biostat or econometrics versus bad AI, the econometrics and biostatistics wins most of the time. Where we really have advances is when you merge the two together and actually lift up, not a huge amount. It's not as much as the AI vendors would have you believe, but it does improve our analytic technique. That's sort of one of my takeaways. This is one of Hadi's great slides, Hadi Karasi. Hats off to some of our bids, biomedical informatics. If you think about, if you have a choice of applying AI to garbage data versus non-AI to good data, you're going to be better off applying non-AI to good data. Better yet would be applying AI and other appropriate techniques to good data. So we can't forget about the whole typical process of database development. And we've all seen overfitting. We've all seen, poor, inappropriate, model specifications. AI, especially now that you can just press a button and get the AI to run, rather than logistic regression, you can, apply neural nets or something. So we need to be very careful. And so much of the current AI literature suffers from lack of this. Some examples, you've heard about supervised and unsupervised. Supervised means humans working closely with the machine. That's my preference. There are unsupervised techniques that can end up putting patients that don't belong together, organizations that don't belong together, but the model has high explanatory power. And no one understands it. The AI folks have come up with something called XAI, which means explainable AI. And of course, you've heard a lot about bias. Well, of course, bias in AI is very important. And it's great that computer scientists and computer vendors have identified those things. We've all known for years, there's so many sources of bias, many concerns of equity, and explainable. Did you ever try to take an econometric model and share it with a hospital administrator or a head of a department? It's challenging, and so we've known about explainability for a long time. But these are things that are being relearned by some of our colleagues. All right, that's an example of a neural net, which basically using brute power. Someone told me that every ChatGPT run uses a case of water, and every deep neural net uses a swimming pool of water to cool the core NVIDIA. I don't know if that's true, but I read it in The Guardian or something like that. But the point is we need to, if we're going to do that, and I'm not even talking about, and that a lot of these companies are now opening new coal plants to fund. I'm not saying that there can't be trade-offs and we shouldn't use some of this raw power, but it needs to make sense. It needs to make sense. All right, moving on. This, when you look at these slides, this was a really cool study out of Singapore. They have data across the whole population for many years. They very methodically, for different populations, developed the kind of AI models that we see in any JAM AI or JAMA AI every day. They're small studies, limited populations, less limited than the whole country. And they cherry pick one or two analyses, and they don't necessarily compare it to standard analyses. In some cases, the new techniques are better. You're not hearing me say AI never works, but in other cases, they don't. This is one of my favorite studies. I'm sure it needs updating, but it compares 282 different predictions, and what they discover, which ones are better for machine learning, which ones are better for regression. What they discovered is those that are biased studies favor machine learning, and those that are non-biased studies favor not machine learning or a balance. So this is just some evidence. I hope people update it on my point that AI alone is not the answer. All right, and this is some examples of the AI work that we're doing, including trying to figure out appropriately how AI fits into ACGs. All right, I don't need to talk about bias here. I think most of you know it's a huge issue. If not, this was an article I thought was good. It was the British Medical Journal, one of its publications said, does AI stand for augmenting inequality? I thought that was witty, and the Brits have a witty way among them sometimes. And then I think most of you also have seen the HHS, Federal Health Agency, has a whole roadmap. Some of you know Khadija Fairman, I think she's probably online, is doing a lot of good work in this space. So every project, particularly if it's going to have an impact, must deal with the whole bias and algorithmic approaches to minimizing the bias. All right, so I'm on time, and I'm gonna stop in about 5 minutes to allow 10 minutes of discussion. So regardless of what I think, clearly big data, AI, and all of that is here to stay for the future. I think it'll become more normal. Hopefully, you know, and not, they won't talk about, I joked with the editor of the New England Journal AI, one day there'll be New England Journal with no add-on, and then there'll be New England Journal non-AI, meaning that everything will be AI as a component, and then we'll talk about analog medicine. So
I thought AI stood for actual intelligence.
Actual intelligence, that's good. But all right, so the next slides are where I hope, as colleagues, you know, we at CPHIT hope to work, we are working in this space, hope to expand it, where we as a university, there's all kinds of initiatives. Certainly I'm not the only one talking about it. Of course, there's all kinds of things going on at the Whiting School. What's FAISE? What does that stand for? Albert, you were sending that out at the Public Health School. There's an AI initiative. It's really, I almost don't want to call it AI, but it's really, you know, the new science, the new digital science. You know, how do we take advantage of all these things? And I just have a few suggestions. And then I propose that we use the next date, which is the 3rd of December, to have a continued discussion. So I've made all these points already. The first one is whatever we do has to be meaningful to patients, providers, and organizations. It's certainly not just about the AI tools, but about all these other things, messy data, complete data. Clearly, I want to call out the electronic health record. Kudos and thanks to so many people toiling in the domain of electronic health records here. But we really need to up our game, making it available, linking data, not having a gazillion firewalls at the same time, protecting confidentiality. Most of our patient records are in there one way or another. But we can do better. And also a reminder to any of you currently using the EHR one more time, whatever you're looking at in an EHR is wonderful, but there's more than you're missing than you have. Okay, and I can elaborate that on that further. Meaning there's so much about the patient and their care that is usually not in the EMR that you're looking at. So we need to really up our game on the EMR. I've already talked about social. I think that so much of what we do in medicine are the free texts, so the NLP, and the ChatGPT is a whole topic in itself. But to me, within this domain, it's the NLP and ChatGPT overlap. I think that we must balance complexity of these models, bias of the models, lack of transparency. I figure that if people like us can't understand many of the models, what's going to happen to a regular clinician, a regular administrator, a regular patient, do they deserve to understand it? I don't know. That's an interesting question. Do your patients understand every algorithm that you use? Probably not. Does a hospital administrator understand everything that he or she uses? Maybe not. But they're certainly not going to understand the AI, and that's not up to me to decide. I think that that's probably enough. I do want to focus this, since this is a co-sponsored by CHSOR. Now, there's obviously analysts in the HSR field, econometricians, statisticians, but the whole field of our business as health services researchers is to assess impact, to assess efficacy, to assess efficiency, and of course, equity. And if you think about not the micro aspects of the AI, and this is going back to the 4 categories of AI, that could include switching over to a ChatGPT interface, again, not my area of expertise, or the clinician using Chat GPT to help him or her. Switching over to AI supported scan of the retina or AI supported mammography. I think we should play an important, and of course, looking at the big data. I think we need to increasingly think about our role as evaluators. All the stuff that we apply on a non-AI intervention is even more complicated to assess on an AI intervention. There was in the New England Journal AI, I sent it out for those of you that were on the HPHI. There was a group of 10 scientists from Israel at Clali, their HMO. Israel is one of the most wired healthcare systems, and they have developed, the health services researchers there, a whole framework for doing health services research and outcome in an AI context. It was almost too much of a framework because there are like 20 items. But I think we all need to up our game, even if you don't know anything about AI. I mean, I've done many studies on clinical things and technology that I know little about. I understand its implications. So you don't have to fully understand the AI as long as we understand the context and how our results can be used.